Now, Professor Timothy Hughes is from the University of Adelaide, whose work seeks to narrow the divide between leukemia patients who respond to the drug. I'll get it right eventually, Tim. You better say it. Imatinib, and those who don't.
Okay, thank you very much for the opportunity to talk at this really inspirational session. My focus over the last 20 years since becoming a haematologist and a researcher has been to better understand and therefore better manage patients with chronic myeloid leukemia. This is a disease, a cancer which in some ways is relatively simple because it's driven by a single oncogene, the fusion of the BCR gene with the ABL gene forming this BCR-ABL oncogene, which is an activated tyrosine kinase, and therefore signals through phosphorylation of specific substrates driving these cells to transform. So if you put BCR-ABL into a mouse, you can actually derive the disease of CML, proving that this is causative. And in the 90s, technology became possible to design molecules that could specifically compete with ATP in this kinase domain and therefore block the kinase activity of BCR-ABL. And as you would predict, it's the kinase activity which is critical to the transforming capacity of this oncogene. So imatinib was the first developed tyrosine kinase inhibitor in cancer therapy. Since then, we've had the pleasure of having a second generation of kinase inhibitors for CML and very recently a third generation, improving on the design of imatinib, although it remains a remarkably good drug. This is the survival that Michael mentioned, the quote that I made about my patients in the 90s, this slow decline in health and early death. And this is a disease where the average age is 55, so many young mothers, fathers, children with this disease. And so that by 10 years, only about 10% were surviving, with the best available therapy in the 80s and 90s, which was interferon, alpha interferon. We now have the experience with imatinib, where there's only about 10 to 15% of patients who are dying of the disease out at 10 years, and most patients are indeed living normal lives. So if you look at the actual response in a patient who starts on this kinase inhibitor therapy, imatinib, you see a dramatic fall in the amount of leukemia in their blood. We measure by the PCR test of the transcript. It goes down 1, 2, 3 logs. And we showed some years ago that below 3 logs, the chances of the disease transforming into an acute leukemia were very close to 0. However, there are patients who don't respond well initially. There are patients who respond dramatically and then lose response. And these have been the focus of our research over the past 5 or so years. And what we have recognised is that these patients who respond poorly may in fact have a different intrinsic sensitivity to the tyrosine kinase inhibitor. And we actually measure that directly by, here in this study, taking 60 patients and measuring directly by putting in increasing concentrations of imatinib and measuring the dose of imatinib at which you got 50% inhibition of the kinase activity in that patient. You can see some patients required very high doses of imatinib to actually achieve this level of kinase inhibition, and some patients remarkably low levels. And when we looked at this cutoff of the median value, the outcomes was excellent for these patients and not as good for these patients, suggesting this was indeed a predictive test of response. Now, this surprised us because all the patients have the same BCR-ABL oncogene. We don't see mutations at diagnosis like are seen in other diseases, so it wasn't clear to us why there was such a major variation in sensitivity. And it led us into studying the way that this drug actually gets into and out of the cell. And we, as well as other groups, identified that the organic cation transporter 1, or the OCT1 influx pump, was critical for the uptake of imatinib into the cell. In some patients, we developed an assay, an OCT1 activity assay. We could show that some patients, their leukemic cells actually were very inefficient at taking up the drug, and these patients predictably respond poorly to therapy, whereas other patients take it up very efficiently. So we developed this assay, the OCT1 activity assay, and it proved to be even more predictive than the IC50 assay that we developed 5 years before it, and has become a very critical assay in the assessment of patients at diagnosis with chronic myeloid leukemia. So here we have just recently published the 5-year outcomes for our recent study in which patients who had high OCT1 activity, that's 75% of patients who were above a certain mark, none of those patients have transformed, and in the lower 25% of patients with the lower 25% of OC1 activity, we see all of the patients who actually transform. So this was an important confirmation of the very important predictive value of this test. So in summary, patients with low OC1 activity respond poorly to imatinib, and the really exciting finding that we made a couple of years ago was that the second generation inhibitors that were really designed to contend with the mutations that we're seeing with imatinib happened to also have another major benefit. They weren't actively influxed by OCT1. They were passively taken up. So patients with low OCT1 activity should not have inferior outcome with these new drugs. We're yet to actually prove that, but that is certainly what we'd predict from our studies so far. So we've made this assay available in Australia, and over the last few years, over 400 patients have had the assay performed in the Adelaide laboratory. And so 400 patients now have a measure of OC1 activity, and their clinician can use that data to decide whether to go with the first-line therapy, which has got a long track record and is a very safe drug, or to use one of these newly available second-generation drugs that clearly would have particular benefit in the patients with lower OC1 activity. So it really is being used as a guide to personalised therapy. Now I want to finish by acknowledging that the majority of this work was supervised by Deborah White. And many people in the laboratory contributed to the work, particularly Jane Engler, one of our talented PhD students that did some of the critical work to further understand the role of OC1 activity. So now we're going on with other PhD students to try and develop a better assay for OC1 activity, because it's a rather cumbersome assay at the moment. We'd like to develop much as what we've already heard, a kit-based assay that could be actually exported widely so that people internationally could have access to this important assay when deciding how to treat their patients. Acknowledge also there are very important co-investigators on this study that are also mentioned here. And finally, I really thank NHMRC for this opportunity and for the wonderful support that they've provided for this work over the past few years. Thank you very much.